where your immune system decides to launch an attack on your own myelin sheaths. So this leads to inflammation and sclerosis or death of the myelin sheaths themselves in the central nervous system. So remember, your axons are like electrical wires, and the myelin sheaths provide the insulation. So in multiple sclerosis, the insulation itself is damaged, and it's an autoimmune disease, like I mentioned before, and it's been linked to there's genetic correlations, but also environment plays a huge role in triggering the immune system to launch the attack. So as the name suggests, multiple sclerosis, there are many or multiple lesions many or multiple lesions in the actual myelin sheaths themselves. Now, MS has various different clinical courses. The most common being what's called relapsing remitting. So we'll take a look at that soon, relapsing remitting. And that one is the most common. And what it does is patients go through periods of exacerbations or flare-ups and then periods of remission. So they get some kind of reprieve at some point, right? But they do have these series of normal periods, which then have series of exacerbations or flare-ups. So overall in MS, right, because they're losing their myelin sheath, it slows down their nerve conduction. But multiple sclerosis occurs in the central nervous system. So it's limited to the CNS, it's limited to the cerebellum, the spinal cord. And as a result of that, in the brain and the spinal cord, you don't have the ability to regenerate the myelin and regenerate the axons very well in general. So the damage that's done in MS is permanent. So overall, it's chronic, long-term. Demyelinating, meaning the myelin sheaths become sclerotic and have lesions. And it does affect young people. I would say average, when people are diagnosed with MS, they're diagnosed in like their 20s or their 30s, sometimes in their 40s and 50s as well. And women are affected more than men, just like most autoimmune diseases. And we don't know why this happens, but the immune system does launch an attack on the myelin sheaths of the central nervous system. But environment does play a huge role. Stress is one of the #1 reasons that they believe triggers for MS. So the demyelination can occur throughout the actual central nervous system, but lots of times it's mostly in the spinal nerve tracts and the oculomotor and optic nerve, which then leads to symptoms that are associated with like double vision or poor vision. The patients tend to be weak or have poor coordination if it's in the cerebellum. They may have sensory defects in the spinal cord is affected. Things like bowel and bladder control are affected. So the manifestations really just depend on where the lesions are, right? In the brain, it's in the brain and spinal cord itself. Overall, I would say majority of the disease course is linked to the exacerbations and remission. Hence the relapsing remitting being the most common type. And in terms of managing, you typically need to manage based on the type of symptoms that they have. They will do steroid therapy to help during your exacerbations, right? And of course, taking immune modulating drugs to kind of manipulate the immune system or help to suppress the immune system, as this is an autoimmune disease. So in terms of the different clinical courses, right, relapsing remitting being the most common form has your exacerbations and remissions that are clearly defined. Your other clinical courses would be primary and secondary progressive. And I would say the most rare and definitely most detrimental form of MS is a progressive relapsing multiple sclerosis, where the first exacerbation you have is just going to continue forever. There's just no recovery, no reprieve. There are no remissions. And as you can see right here, depending on where your area of lesions might be would depend on where your area of dysfunction might be, which then leads to the different manifestations you might have as a patient who suffers from multiple sclerosis. Okay, Any questions on that? Does that make sense? All right, so that brings us into spina bifida, which is actually the most common cause of neural tube defects in the developing fetus. And spina bifida literally means cleft of the spine, or, a cleft in the spine. So what ends up happening is when the spinal column is developing around the spinal cord, there's a gap or cleft. No, you don't need to know the percentages, Dan. Just which one are more common than others. Yes. There's a gap or cleft, and that cleft causes for the spinal cord itself not to be protected as it's being developed in utero. So that cleft in the spine allows for incomplete development of the central nervous system. So incomplete development of the brain, the spinal cord, or even the meninges itself. So what you have is a defect in the closure of the bony encasement around the spinal cord itself. So environment plays a role. We know that lack of folic acid plays a huge role in spina bifida. Genetics plays a role, right? And maybe infections during pregnancy like rubella plays a role as well. And in terms of the different types of spina bifida, you could have what's called spina bifida occulta, which is actually a asymptomatic spina bifida, right? You don't really have any true exacerbated protrusions out of the spinal column. As you can see here, right, there is an incomplete sac, right, that external sac, but it doesn't really protrude out of the column too much, as opposed to a meningeal where the sac itself does protrude out of the spinal column, but there's nothing in the sac. So when someone suffers from a meningeal, actually, the sac itself, because it's filled only with cerebrospinal fluid, no spinal cord, then you may have no symptoms at all or very few symptoms, right? Some patients may have like an incomplete paralysis, maybe some bladder bowel dysfunction, but where you really have the problem is the mild meningeal, where, as you can see here, the sac is exposed, not just cerebrospinal fluid, but also the meninges and a portion of the spinal cord. So like, for example, these babies right here, you can see that they're suffering from a myelomeningeal because there is a literal extension of the central nervous system tissue through the defect, through the vertebral column, right? And exposed to the outside world, which means that it's going to be damaged. And we know that central nervous system tissue cannot be regenerated. So it mostly occurs in what's called the lumbar sacral region, as you can see here. Patients usually have motory and sensory deficits in their lower extremities, problems with bowel and bladder control. And then, as you can see here, the skin is very thin over the defect, and it ulcerates the skin, and compounded infections are going to be a complication of the actual spina bifida itself. But the good thing is there is actually fetal surgery that you can do in utero, where they do it on myelomeningeal patients. So, and it has really positive outcomes. It reduces the death of these patients. There are even patients who are able to utilize no assistance, like no kind of braces or wheelchairs. It allows for really having better leg function overall when you do the surgery. So what happens is the second trimester, you do the ultrasound, they'll probably see this spina bifida, and the surgery is done about the 20th to the 25th week of the pregnancy. And they go in and they close the cleft. So all the nervous tissue that's already damaged is already dead, but there's still half of the pregnancy still left for development of the central nervous system. So once they close the cleft, the spinal cord and is now safe, right? So the rest of development will occur as it should. So the key is to prevent infection and, of course, protect those exposed nerves. Now, the higher the defect is in the back, obviously, the more damage you're going to have, the more symptoms you're going to have in terms of the extension of lack of control. but the lumbosacral region is the most common place that it will be. All right, any questions on that? Okay, so that leaves us with ALS, which is amyotrophic lateral sclerosis, so also known as Lou Gehrig's disease. So Lou Gehrig's disease results from death of the lower motor neurons in the spinal cord and brainstem and the upper motor neurons of the motor cortex. So what does that tell us? We have a loss of motor control. Now, sensation is not affected in patients who have ALS, so it is strictly a motor loss that they have. So essentially, the patients who suffer from ALS are mummified in their body, right? They have muscular atrophy, muscular weakness, paralysis, and weakness of all voluntary movement, but sensation is not affected any at all, right? So it's like they get this apoptosis of the neurons. So there's some kind of genetic correlation, but most patients who develop ALS, it just comes on unknowingly. So it has a more of an unknown etiology. And the only treatment that they have right now is a glutamate inhibitor, but it only prolongs your life for several months. And either way, you're going to die of respiratory distress. It may help to delay the respiratory mechanical device use, but I mean, the patients are going to die from respiratory distress. So essentially, if you remember anything about the spinal cord, the gray matter, right, looks kind of like a H or a butterfly. Information comes in posteriorly, leaves anteriorly for motor neurons, and leaves laterally for autonomic nervous system. Well, these anterior horn neurons are what's dead, okay? And as a result, motor function is dead as well. And the corticospinal tracts, the lateral columns, those are also degenerated. So motor movement is just not happening in these patients. So in terms of your manifestations, we're going to be looking at things like muscle wasting, muscle weakness in the extremities, impaired speech, impaired swallowing overall. And then I would say the onset is very gradual, varies from person to person. Some people have trouble like grasping pens or holding their coffee mug. Some people have their voice pitch change. It mostly starts with the muscles that affect like the arms, the legs, the feet, and speech. So patients are going to do things like trip over their own feet, drop things, have abnormally fatigued arms and legs. I always tell my students that my stepmom's best friend died from ALS a few years ago, and she was a physical therapist. So how she knew that something was wrong is that she couldn't manipulate her patients anymore. Her hands were just too weak, and her arms and legs were just too fatigued all the time. And then when she went for testing, she was diagnosed with ALS. So and for my students, I always say when you have some free time, be sure to get a copy and read one of the most amazing books ever written called Tuesdays with Morrie, which is a book about a college professor who was diagnosed with ALS. And his journalism student came back and sat with him for a while and wrote basically a little bit about his journey of ALS, and it's a really great book to read. It gives you really good insight on patients who have ALS. ALS is very difficult to diagnose. No one test or procedure can diagnose it. You would do like a series of like MRIs, muscle and nerve biopsies, EMGs that monitor like the electrical activity of the skeletal muscle. Overall, I would say most patients die within 3 to 5 years from respiratory distress. Some patients live for 10 years, some patients live for 20 years, but majority of patients die very soon. The prognosis is usually no much more than 5 years at a time, and they will die from respiratory distress. So any questions on that? Okay. So spinal cord trauma, right? One thing I would say that you guys should make sure you know or understand is the fact that you've got your spinal nerves innervating different parts of the body, right? So the level of injury really is going to be based on where you have the loss. So I would say, C3, 4, and 5 keep your diaphragm alive. So things like innervation of the diaphragm ends up with um, a diaphragm that is paralyzed would probably lead to death, as opposed to, thoracic nerves being damaged, more like upper and lower extremities that have defects, or if your lumbar sacral nerves are damaged, just more like lower extremities that have the defects. So depending on your level of injury, either you'll have death, quadriplegia, or paraplegia, right? Patients who have spinal cord trauma, especially if we're talking about the fact that they're immobile, they're at risk for things like blood clots in the legs and abdomen that can travel to the lung and the heart and cause for further complication. They may be susceptible to pneumonia, especially because they're not mobile, susceptible to things like bed sores. When patients have spinal cord injuries, the spinal cord is compressed, like maybe a bony structure is compressing it, or it could be contused, which means that there's a bruise but no break, and then or it could be transected, which means that there's a physical break, right? And secondary complications to your spinal cord injury could be anything from hemorrhaging to swelling and compression to ischemia in the area. But most of the time when people have a spinal cord injury, it's usually some kind of trauma that caused it, right? A motor vehicle accident, maybe a stab wound, or some type of sports injury or fall that they had actually gotten. Whiplash injuries, I would say, are the most common type of spinal cord injury. Superman, I can't remember what is his real name. Superman, he fell off the horse and then he ended up with quadriplegia due to spinal cord injury from whiplash. I can't remember his name right now, but he had the whiplash, which is the hyperextension, which caused for damage in the cervix, damage in the upper portion of his spinal cord, which led to him suffering from quadriplegia for the rest of his life. So your loss of function occurs pretty much anywhere below wherever your injury might be. So like I mentioned before, it could be a compression, right? And that compression is just anything that is just pressing on the spinal cord, disrupting its function. It could be a tumor, it could be a hematoma, it could be some kind of bone that's compressing it, like from the spinal column. If it's some type of trauma, Christopher Reeves. Thanks, Alvara. I was like, what is that man's name again? I'm seeing him right now in my head, but I could not remember his name. Right. Blunt trauma could cause a contusion. Penetrating trauma, like stabbing, would just, transect the tissue itself. But either way, once you have the injury, you're going to lose the function, right? So whenever you have any kind of spinal cord injury, you have what's called spinal shock that occurs thereafter. So spinal shock is basically where you have temporary loss of your reflexes because of the injury. So the muscles are flaccid, your autonomic reflexes are lost, your skeletal reflexes are lost. But the spinal shock only lasts for a few hours or a few days or a few weeks. So that usually, you recover from it. Neurogenic shock is an issue. Neurogenic shock may occur after the spinal cord injury, and it's due to the fact that when the spinal cord becomes injured, the sympathetic nervous system becomes depressed. So the sympathetic nervous system doesn't work anymore. And as a result, it can't tell your blood vessels to stay toned. So the smooth muscle walls in the blood vessel loses its tone, and then all of the venous blood just starts to pool, right? So blood just pools in the venous system, which means that it doesn't get returned to the heart. And if it doesn't get returned to the heart, it doesn't get oxygenated. And if it doesn't get oxygenated and returned to the heart, you have decreased cardiac output. So overall, your blood flow kind of diminishes, which makes the patient gets extremely hypotensive. And as a result of that, they go into circular collapse, right? So when patients have this neurogenic shock, they're at risk for circulatory shock or circulatory collapse. And also it can affect the respiratory muscles, leading to respiratory failure. So neurogenic shock has to be immediately treated for patients who suffer from spinal cord injuries if it happens, and it can lead to death. these are the case for spinal cord contusions. Yes, so this can happen in a contusion. It can happen in a transection, like if it's the spinal cord breaks. Yeah, or even in a compression. So this kind of gives you an idea of like, where the spinal cord is affected and how it might be manifested in the patient. So, something like C4, C5, we're talking about the diaphragm, the head area, the um, the shoulder area, right? Anything about C6 or 7, we're talking about, because we're talking about the brachial plexus now. So we're talking about the arms, the upper extremities. When we look at like T1 down to T10, we're still looking at that kind of more upper part of the body. But once we get into like the lumbar sacral regions, then we're talking about like the lumbar plexus, the sacral plexus. So things like lower extremity movement, things like bowel and bladder function, that will be affected. So try to think of the levels and of where it may be injured, and then look at your manifestations associated with that level of injury. So in terms of the treatment of the spinal cord injury, well, obviously we need to stabilize the vertebrae, right? Could be accomplished with external fixation or bracing, or actual surgery itself. So the spinal column, steroids, man, high dose steroids, you have to suppress that inflammation, right? Especially because you don't want any kind of secondary injury from the spinal cord injury itself. And the patients usually end up in very intense rehab because you want to get that function back. Okay. So that leaves us just with our peripheral nerve system disorders, and we're only doing 2 of them, Guillain-Barré and Bell's palsy. So Guillain-Barré, also known as an idiopathic polyneuropathy, basically what happens is this. When someone suffers from Guillain-Barré, the myelin sheaths of the peripheral nervous system, remember now we're in the peripheral nervous system, the peripheral nervous system are damaged and inflamed. But because the peripheral nervous system, those Schwann cells are in the penis, right? Yes, Schwann cells are able to conduct regeneration, right? Patients who suffer from Guillain-Barré, most of them spontaneously recover because the myelin sheaths are able to regenerate. So what happens is you have something like the stomach flu or like a respiratory infection, right? Or you suffer from like Zika or, something like CHIKV or something like that. And then your immune system is, launching attack for this virus, but then it feels the need to launch an attack on your peripheral nervous system myelin sheaths as well. And as a result, the myelin, you get demyelination of those peripheral nerves, as you can see here, leading to not having the innervations you need into the skeletal muscles. So with that being said, I would say for the most part, when we're talking about treatment, most of it is supportive treatment because you spontaneously recover from it. But I mean, if some patients have to undergo like physical therapy or occupational therapy, depending on how much disruption has occurred. Last but not least, or last disease or disorder for the entire unit is Bell's palsy. And Bell's palsy occurs because of inflammation of cranial nerve 7, which is your facial nerve. And it's usually unilateral because usually it's not both nerves that are affected, just one. And the facial nerve makes sure that you have movement of the facial muscles. So these patients who suffer from Bell's palsy have a facial droop because it's paralysis of the facial muscles. They have diminished eye blinks, or their eyes are always open unless they physically go to shut the lid itself. And they have decreased lacrimation. So when someone suffers from Bell's palsy, you need to make sure you rule out conditions like stroke or infections or tumors, right? And rule to make sure it's nothing like that. And then after that, they will be diagnosed with Bell's palsy. Oh, really? Yeah. So interestingly that you would say that because when you treat for Bell's palsy, most people recover without any kind of treatment, but some people get physical therapy afterwards, right? So depending on whether or not like there was like rigid physical therapy afterwards, maybe that could have made a difference. But most of the time, people recover fully without no treatment, which is probably what happened, or they just probably didn't just treat you for it at all. But sometimes they give physical therapy to help to make sure that there's no long lasting effects. Of course, corticosteroid to reduce the swelling of the facial nerve. And if it's caused by some type of infection, they'll give like an antiviral along with like prednisone, especially if it's severe. But most of the time, the treatment is supported because you spontaneously recover. But like when you, like for example, when you sleep beside someone with Bell's palsy, because their eye lid is innervated by these muscles, the eyelid can't close. So they're sleeping, but that one eye will remain open unless you like physically shut it. You can have a relapse. Yeah. It just really depends on what is triggering for the facial nerve to have inflammation. So if there's something that's continually causing for inflammation of that cranial nerve 7 for that individual, then you could have the relapse for sure. So what else? Yeah. So when you're diagnosing with someone with Bell's palsy, you might say to them, okay, can you move your facial muscles, right? Can you close your eyes? Can you lift your eyebrows? Can you smile and show your teeth? Can you frown? And normally they can only do that on one side of their face. And then they're diagnosed with Bell's palsy thereafter. And then you can be given like steroids to reduce the inflammation of the cranial nerve. And once the cranial nerve inflammation is decreased, then the Bell's palsy will recover thereafter. Yeah. Any other questions on that? Whoa, we're done. Damn. Any other questions on that? No other questions. Really? Nothing else. Well, if that is the case, oh, the book that I mentioned is Tuesday. Let me write it in the chat. Tuesdays with Morrie. It's an awesome book. It shouldn't be expensive to buy either. It's like super small book. Yeah. It's a really great book, really good read. As if you guys have like more free time, but yeah. The note to dance. So you can relapse if whatever is, to answer that question, you can relapse if whatever is causing the inflammation is something that's concurrent for you. Yes. So you can have it more than once. So the cause for the most part is unknown. Yeah. Unless it's related, unless you know that, okay, so for example, some people may have Bell's palsy because of like a herpes infection, right? So then we know it's caused from like the herpes infection. You know what I'm saying? But for the most part, sometimes it just happens. There's something that's triggering the inflammation and they don't get a chance to figure out what that is. Not necessarily like a genetic component as such. Yeah. Perfect. Okay. If it's viral, they usually give like Valtrex or some kind of antiviral like that, and then give the prednisone thereafter. But that would be the best way to. Prednisone is a steroid. Prednisone with a D, not a G. Oh, why? You said why? Because you want to decrease the inflammation. It's a steroid, so you want to decrease the inflammation. Yeah, cool. Good. I knew you guys had questions. I couldn't imagine you have no questions at all. That's not even like you people. All right. Anything else, my friends? All right. All right, guys. Well, that is it. I will see you next week and everything will be great. All right. And then as soon as I know when I'm going to do when we have the review sessions, I will post them on the web courses in the announcements along with the Zoom links. Have a good rest of the week. Have a great weekend. Enjoy yourselves and enjoy the fact that we got out early today. All right. I'm going to go cast my ballot right now. You guys make sure you vote. Throwing that out there. All right, guys. If you want to ask questions about the quiz, you have to send me an email, Hannah, and we can do it on a conference. And the case study will be Monday. Absolutely. All right, guys. So just drop me an email, Hannah, and we'll set up an appointment and we can go over the quiz for sure. Perfect. Yeah, absolutely. All right, guys, take care.